Okay, so in this video we'll talk about pressure support. It's a mode of ventilation that's oftentimes used in people who are uh, breathing a little bit better spontaneously and need a little bit more control over their breathing pattern. With pressure support, you will once again set an inspiratory pressure level, or we just can sometimes refer to as the pressure support, maybe something like 10. Once again, set an FiO2, maybe 40%, and once again set a PEEP, maybe something like 5. With pressure support, you don't set a backup rate. There's no backup rate in pressure support. Not that there couldn't be, but that's just the way that the mode was originally, I think, thought of as sort of a mode for people who are getting close to extubating, who don't need that sort of high-level support. And what will happen here is, once again, if we're measuring pressure, tracing out pressure and tracing out flow, at the end of a breath, alveolar pressure 5, airway pressure at the Y 5, if the PEEP is 5 and there's no flow. So airway pressure is 5. Once again, the patient will have to trigger the vent, so we'll see a little drop in airway pressure. And then once we switch over to inspiration, the expiratory valve will close, the inspiratory valve will open, and the ventilator will put in 10 more than the 5 of PEEP. So in this case, the ventilator will put in a pressure of 15. At that point, alveolar pressure is presumably something like 2 because you just trigger the vent. So you've got a pressure gradient of 15 here to 2 here. So of course you have inspiratory flow. And once again, as air gets pushed in, alveolar pressure will rise, maybe get up to something like 10. As alveolar pressure rises, flow will decrease because we don't have such a big pressure gradient. In this way, it's a lot like pressure control so far, right? There's one big difference. We don't have an inspiratory time with this mode. We didn't tell the ventilator to maintain inspiration for a certain amount of time. Instead, we tell the ventilator to maintain inspiration until the flow decays to a preset percentage of peak inspiratory flow. Now that's a mouthful, so let's say it again. We're going to keep inspiration going until the flow decays to a certain percentage of the peak flow. Oftentimes we'll say 25%. That's the usual. So if peak inspiratory flow is something like 60 liters per minute, then when the flow gets down to 15 liters per minute, then that's what tells the ventilator to stop inspiration and switch over to expiration. So however large of a volume the patient got, at some point, again, flow is going to decay. When it gets to 25% of peak inspiratory flow, then we're going to close the inspiratory valve, we're going to open the expiratory valve, and we're going to let expiration take place. Because again, we'll have some pressure here that's going to be higher than the PEEP. And just like in any other situation, eventually the alveoli will empty and should get back down to the PEEP, and there should be no flow. Now, if the patient makes a sustained inspiratory effort with their inspiratory muscles, then that will help to keep the airway pressure low, the alveolar pressure low, and help to maintain that flow. So the patient will have some impact over things like how fast the air is coming at them, the flow rate. The patient will have impact on how long inspiration goes on for, and the patient will have some impact over how big of a breath they get. Now you might say, what's so special about 25% of the peak inspiratory flow? Well, you know, it might match how long the patient wants to breathe in for. Doesn't have to. It might be longer than the patient wanted to breathe in for. It might be shorter. There are certain conditions where you could predictably expect it to be either too long or too short. But, you know, it's a pretty good approximation for a lot of patients. And it does give the patient a fair amount of control over their breathing pattern. If they're sustaining their inspiratory effort through inspiration, and then they say, okay, I think I've got enough of a breath, and their respiratory centers stop telling their inspiratory muscles to breathe in, then that muscle pressure kind of goes away, and that's oftentimes enough to slow the flow down and hit that magic 25% mark, and that helps and then that gets the breath to end. So the patient has a fair amount of control. It helps if usually helps if the patient is a little more awake and a little bit more ready to breathe spontaneously. compared to a patient who's maybe heavily sedated. But all of this, can be individualized and depends on the circumstances of the patient. Okay, so those are the basic modes of mechanical ventilation. In our next series of videos, we'll talk about some physics and some physiology that I think is really important to make sure we have straight in our heads before we go on to try to deal with complicated cases. Thanks.